I just did my spiel, but I'll do it again because I think I had the wrong button pressed. Welcome, everyone. Welcome this evening to our webinar. We will begin in a few minutes. I'll just allow everybody to get their computers set up properly and get your drink beside you and that type of thing. So you won't hear us talk for a moment, but then we'll join you at about 5 after. So welcome and hello.
Good evening. Good evening.
Keep watching the number of attendees climbing up, so I wanted to jump in when it paused for sort of a minute, but it seems to keep on climbing. So I'm going to give it a second here, and we'll wait for the bulk of our people to join. But thanks again for joining us this evening. We're so happy to be presenting this webinar to you tonight, and such an important topic is fetal alcohol syndrome. So thank you so much. We will begin actually with a little bit of introduction. So I'll introduce myself. My name is Robin McMillan. I'm the Innovator of Projects, Programs, and Partnerships at the Canadian Child Care Federation. I've been at the Federation since 1999, and before that I was a frontline early childhood educator. So anyway, we're doing a very interesting webinar this evening, and it's amongst our collection of webinars that some of you probably have joined us for before. We're doing these free Wednesday webinars, and what we offer at the end of the live webinar is a 1-hour professional development certificate. And just so you know, those certificates are auto-generated for all of those who attended the live webinar event, and you have to be registered individually to receive those certificates, and they will be arriving to you by email 2 days after the webinar. So by the end of this week, you'll be receiving those. And before we go much further, I'm going to introduce Suzanne, and then after Suzanne, I'm going to come back and introduce Kathy, our presenter for this evening. So Suzanne, over to you.
Hi, I'm Suzanne.
About yourself? Yeah.
Thank you, Robin.
I'm Suzanne Schlechte from the Canadian Child Care Federation, and I think we have a video that I've put together with our land acknowledgement and a couple of upcoming things for the CCCF. Robin, can you play that?
Good evening. Welcome and thank you for being here with us tonight. I'd like to get us started with our land acknowledgement. As we gather together on this virtual platform, we acknowledge that we're each joining from the ancestral or unceded lands of Inuit, Métis, and First Nations peoples. The Canadian Child Care Federation's office is located on the traditional unceded territory of the Algonquin Anishinaabe people. We honor their enduring connection to the land, waters, and culture, and we recognize all Indigenous peoples who have lived on and cared for these lands since time immemorial, those who live here now, and the 7 generations to come. We recognize the harms and injustices of the past and the ongoing impacts of colonization. We affirm our commitment to truth, reconciliation, and meaningful collaboration with Indigenous communities. As Indigenous peoples have always done, we strive to be responsible stewards of the land and to respect the cultures, ceremonies, and contributions of all who call it home. We invite you now to take a moment of reflection, and if you feel comfortable, to share the name of the Indigenous lands you're joining from in the Q&A or chat box. Let us honor the many peoples and places across these lands and consider the tangible steps each of us can take to move forward in a spirit of truth, reconciliation, and collaboration. And while you're doing that, I want to give a shout out to our affiliates. All across Canada, we have many childcare organizations that are our affiliates. I encourage you to check out the organization that might be nearest you. And if you're not already a member, consider joining. Joining one of our affiliate organizations makes you a member of the Canadian Child Care Federation and entitles you to all the benefits and perks of being a CCCF member. I hope you're excited for tonight's webinar. We have a couple more webinars coming up in the future. On September 24th, we have Play with Purpose, Nurturing Oral Language and Literacy in Children from Birth to Age 5. And you can use the link, the QR code, and find out more details and register for that webinar. On October 1st, we have Learn Through Active Play. And once again, more details using the QR code. Finally, I'd like to finish up by inviting you to sign up for our newsletters. If you're not already getting our newsletters, this is a great way to keep in touch. We've got CCCF Insights, and for family childcare providers, we've got a newsletter just for you too. Using the QR code, you can see how to sign up for either or both. And thank you very much for being here tonight. And without further ado, let's get started.
Thank you, Suzanne. So that was great. So what I'm going to do now is I'm going to change presenters so I can allow our presenter, Kathy, to show her screen. So let me just, of course, we practiced this, but I got to make sure I get this straight now. Okay. Now I can't find the right button. Hang on for 1 second. Oh, there we go. Okay. And while we're switching that over, I'm actually going to introduce you to Kathy too, to our presenter. So Kathy Unsworth is the newly appointed Executive Director of the Canada Fetal Alcohol Syndrome Disorder Research Network. She served as the Managing Director before that for over 10 years and has been instrumental in driving forward national initiatives, including development and advocacy for the national FASD framework. Kathy is responsible for provincial and federal government relations, working with researchers to translate science into policy, as well as managing the national FASD database. Kathy employs her background in public health and community development to use evidence-based research to inform programs and policies to improve outcomes for those with fetal alcohol spectrum disorder. So welcome, Kathy. Thank you for joining us this evening on this really important topic that I don't think really we talk about enough and certainly don't know enough about. So we welcome you to, I've turned over to you to inform us all. Thanks so much.
Thank you. Does my screen look okay?
It looks good.
Yeah.
All right, great. I also am joining today, or tonight actually, from the unceded territory of the Algonquin Anishinaabe people in Ottawa. And the CAN-FASD Research Network recognizes the historical significance and contributions of Indigenous peoples and their cultures, and understands the important role that the Indigenous community plays today and in the future. We acknowledge that we live, work, and meet on traditional territories across Canada of many of the First Nations, Métis, and Inuit whose footsteps have marked these lands for centuries. CAN-FASD is committed to act to support our acknowledgements and in particular our work related to the Truth and Reconciliation calls to action specific to FASD. So I'm very happy to be here tonight and very excited to see all of you. Well, I can't see all of you, but I can see that there are 307 of you, which is amazing. So I'm super excited to share the work that we've done in this area and talk a little bit about CAN-FASD and who we are, and hopefully we can have a great discussion. So I'm happy to answer questions if something pops up during. I'm not so familiar with this GoToWebinar format, but I will try and keep an eye. Otherwise, there will be time at the end for questions. So as I said, I'll give you a brief overview of CAN-FASD, which is a research network, and then talk about FASD in the early years, FASD in general, talk about a really cool project that we just launched, and then take your questions. So the CAN-FASD Research Network started with a partnership of the Northern and Western provinces and territories and back in the late 90s, early 2000s. The idea, anyway, the Northern and Western provinces recognized that FASD was an issue, and the ministers got together and had the brilliant idea that if they pooled their resources, they would be able to do more. And so they launched the research network in 2005 officially, and then in 2013, CAN-FASD Research Network was established as a registered charity and non-governmental organization. So it's a very unique organization. We don't give out oodles of money. We respond to and support the unique needs of government policymakers through evidence. And we have strong connections with stakeholders. We connect the researchers and the stakeholders and to create innovative research that's really meaningful to the community, to families, to individuals with FASD. And we develop knowledge distribution methods. So this is what I call our dream team at CAN-FASD. So we have what we refer to as sort of our 5 pillars of research, and the first one being prevention. And some of you may have heard of Dr. Nancy Poole. She's an international lead in prevention, and she works out of British Columbia. We have Dr. Jackie Pye, who's our intervention research lead. She's at the University of Alberta. Dr. Melissa Tremblay is our Indigenous advisor. She's also at the University of Alberta. Dr. Dorothy Baudry is our child welfare lead. She's at the University of Calgary. Dr. Caitlin McLaughlin is our justice lead. She's at the University of Guelph. We have 2 diagnostic co-leads, Dr. Mansfield Mella, he's at the University of Saskatchewan, and Dr. Anna Hanlon-Dearman, who's at the University of Manitoba and is the head of the FASD Diagnostic Clinic, Manitoba FASD Diagnostic Clinic. And then Dr. Jocelyn Cook, who's our national database lead and currently our senior research lead. one of the things that we're really proud of at CAN-FASD is that we are able to amplify the voice of living experience. So we have a family advisory committee that's made up of caregivers, and then we have an AFECT committee, which is Adult FASD Expert Collaboration Team, and they are adults with FASD. And the role of these two committees is really, like I said, to provide that voice of living experience, to identify research priorities based on their own experiences, caring for or living with FASD, and to give us feedback to help us develop the proposals to make sure that that voice is present in all of our work. A few years ago now, we realized that everyone was using sort of a bit of a different definition for FASD. So we actually struck a committee and an advisory committee, and we came up with a standardized definition for FASD that we now see being used everywhere. So which was our intention. So we're very happy about that. So FASD is defined as fetal alcohol spectrum disorder. It is a diagnostic term used to describe impacts on the brain and body of individuals prenatally exposed to alcohol. FASD is a lifelong disability. Individuals with FASD will experience some degree of challenges in their daily living and need support with motor skills, physical health, learning, memory, attention, communication, emotional regulation, and social skills to reach their full potential. Each individual with FASD is unique and has areas of both strengths and challenges. So basically what CAN-FASD does is we focus on stimulating research in key areas. We build relationships with stakeholders and governments and families, individuals, service providers, like yourselves, professionals, and collaborate with all of those stakeholders on key issues. And we turn the research that's being done into usable resources. So it's always surprised when I say that the prevalence rate of FASD is 4%, higher than autism, cerebral palsy, Down syndrome, and Tourette's all combined. So it affects about 1.6 million Canadians. So yeah, it's a lot. Most of those individuals are undiagnosed. A recent study done by Dr. Lana Popova estimates that about 98% of individuals with FASD do not have a diagnosis. So, and that's because our diagnostic capacity in Canada is really, really limited. And by diagnostic capacity, I mean diagnostic clinics. In a lot of the provinces, there are, are less than 10. So 4% means about 300,000 children in Canada that have FASD. And the other research is that populations with trauma and compromised social determinants of health represent a significant proportion of those affected, and many access supports through federally funded programs like CPNP and CAPC program. So as I said, it's more common than autism spectrum disorder, which always surprises people. It's actually 2.5 times more common. It's 19 times more common than cerebral palsy, 28 times more common than Down syndrome, and 40 times more common than Tourette's syndrome. So there are a number of challenges associated with FASD, and we group them into primary disabilities and then adverse outcomes that occur because of those disabilities. So when someone gets diagnostic assessment, the multidisciplinary team is really looking at is looking at 10 areas of the brain. And so everybody that gets a diagnosis of FASD is affected differently. So there are different tests, psychological tests, the multi-together and tests the individual, looking at these individual domains. So in terms of motor skills, they're looking at specific actions that can be carried out according to large muscle groups. So like the gross motor skills like walking, balancing, jumping, and then smaller muscle groups like that are fine motor skills. So more using zippers. The neuroanatomy, the neurophysiology might include structural abnormalities, and some people with FASD may have seizures. In terms of cognition, they're looking at the ability of the individual to think and process information, and the assessment typically focuses on verbal comprehension, so their ability to use and understand language and vocabulary, fluid or perceptual reasoning, so an individual's ability to solve novel visual or nonverbal problems, their processing speed, so the speed with which an individual can take in and respond to information, and then working memory, so an individual's ability to hold and manipulate information in their mind. In terms of language, we're looking at the individual's ability to communicate effectively, both in terms of understanding and producing language. It also includes higher level language skills, such as narrative, like storytelling, and complex abstract comprehension abilities, so understanding something like sarcasm. In terms of academic achievement, we're looking at the individual's ability to learn and carry out work related to reading, writing, and math, and whether or not they're at their appropriate age and grade level. For memory, we're interested in the individual's ability to acquire, store, retain, and retrieve verbal and visual information from their mind, either intentionally, so remembering information for a test, for example, or unintentionally, so remembering how to ride a bike. When we are testing for their attention, it refers to the process of selectively focusing on something specific in our environment, which involves resisting distractions and irrelevant information. And attention is obviously a critical component of learning and memory, and it can refer to inattention, so somebody that has difficulty focusing, selective attention, so difficulty ignoring visual or auditory stimuli in their environment, or sustained attention, so they have difficulty paying attention for long periods of time. Executive function includes impulse control, so it involves the higher level thinking skills used to organize and control our own thoughts and behaviors in order to meet a long-term goal. So the exact components of executive functioning are sometimes debated, but in an FASD assessment, they include working memory, inhibition and impulse control, so often hyperactivity, planning and problem solving, and cognitive flexibility. So other related and overlapping skills include self-monitoring, organizing and prioritizing, and shifting focus from one area or task to another. Affect regulation refers to an individual's ability to change or maintain their feelings or their emotional state through effortful control in order to meet the demands of their environment. So in an FASD assessment, affect regulation is specific to depressive and anxiety disorders as defined in the DSM-5. Adaptive behavior, social skills, or social communication are the daily living skills and abilities that are necessary to function socially and practically in the home and in the community in an age-appropriate manner, such as communication, interpersonal skills, self-care, domestic skills, functional academics like money math, for example. So I know that's a lot of information, but it just gives you an overview of the kinds of things we're looking at when we're doing an FASD diagnostic assessment. And I'm sure when you're hearing the descriptions of each of those domains, you're probably thinking about children that you work with that may have challenges in some of those areas. So the other piece, piece of the pie in terms of the challenges and what happens if they're not these individuals are not supported is what we call adverse outcomes. So bad things happen to these kids. So 93% of them experience mental health challenges as early as age 6 to 11. I mean, in this webinar, we're talking about the early age, so that's why I put a red square around the 6 to 11 age. So 93% of these kids have mental health challenges, disrupted school experiences, involvement with the law, you know, already it's 14%. So, sexually inappropriate behavior, 39%. Obviously, employment difficulties and dependent living, not applicable. But you see these numbers change a little bit as they get older. So moving into adolescence, sort of less new mental health challenges, but much higher disrupted school experiences and much higher involvement with the law. You know, it's continued sexually inappropriate behavior. And then, you know, as they move into adulthood, some of those numbers, you know, employment difficulties, 83%, dependent living, 79%. So, you know, this really paints the picture that early identification, so screening these kids for prenatal alcohol exposure, getting them a diagnostic assessment, and then getting those interventions and those support services in place is really, really important. We, some of my colleagues wrote a great paper. I'm trying to remember when, it was a few years ago now, but characterizing adverse childhood experiences among children and adolescents with PAE and FASD. So looking specifically at, again, at ACEs, we call them adverse childhood experiences, and it was really high for those kids that were exposed to alcohol in utero. Oh, sorry. It's not all doom and gloom. There are lots of protective factors, and I'm sure that you know, these are not going to be any surprise to you, and things that you know, in your work that would make sense and that you see as well. So obviously, a stable and nurturing home environment is a protective factor. Having basic needs met, having no experience with violence or trauma, having access to developmental disability services, early and effective supports, and then getting a diagnosis before the age of 6. There is a lot of research that shows that if they're diagnosed and supported before the age of 6, they have much better, much more positive outcomes. So again, you know, in terms of adverse outcomes, 90% are, you know, experience mental health challenges. It gets even more serious. Rates of suicide are 5.5 times greater for individuals with FASD, and 35% of individuals experience substance use challenges later in life. 30% experience homelessness, 30% are involved in the criminal justice system. Many individuals with FASD have children that they struggle to raise, many of whom also have FASD, and there's significant involvement in the child welfare system. So one of the things that, so this has all been, had all been sort of floating around. We had our research lead in child welfare, Dr. Dorothy Badry, looking at the death of kids in care with FASD, and the numbers were and are astonishing. You know, stats like this, like you know, the Stats Canada reported that in 2021 that about 27,000 kids in Canada are living in foster care, and the current standard of care for these children doesn't systematically address their risk for developmental delay. And so kids with obvious medical conditions or evidence of physical delay that are referred to specialty care, but this frequently involves long wait times. So CanFASD thought, you know, we need to reach folks like you and early childhood educators to, you know, raise awareness about FASD, to provide some training and education so that we can identify these kids earlier and get them and their families the supports they need. So early diagnosis means getting early support, which means improving outcomes. So we talked a little bit about diagnosis when I went through all of the brain domains that are assessed, but it's challenging. It requires a multidisciplinary team. It's very cost and time intensive and resource intensive. There are a wide range of screening tools that can be used. Diagnosis is often not available until the child is 6 or 7. There are very few clinics around the country that will accept kids earlier than that. And the signs and symptoms are hard to recognize, and they get, sort of mixed up depending on the circumstances. They get mixed up with, other issues that the child may be experiencing. And of course, FASD is very, very heavily stigmatized. So in terms of the multidisciplinary team, there's the medical practitioner. Often it's a developmental pediatrician. It includes a psychologist, a social worker, an occupational therapist, a speech and language pathologist, and a clinic coordinator. So you can imagine in a lot of communities, this team is not necessarily available, particularly in rural and northern communities. These experts are and professionals are on, and a team and a clinic. They just don't exist. Not nearly as many as we need, at least. So I wanted to spend a bit of time talking about the strengths of people with FASD, because I always am self-conscious about describing all of the challenges and the adverse outcomes, and it always comes across like it's this hopeless situation. And they have so many strengths. They have very strong visual memory. They are very creative and artistic. They're musical. They play instruments. They're athletic. They're very honest. They're usually very highly moral. They're loving and caring and kind and sensitive and affectionate. They are very trusting. They usually have very good senses of humor. They work hard. They're very gentle, and they make, they're great storytellers. They're good with animals, and they make, loving kids and loving parents, and they're loyal and faithful. So with the great supports, they can be very, very successful. So in terms of principles of practice, we like to emphasize consistency. So within schools and home and support systems, and obviously, within early childhood education programs as well. Collaboration, so collaborating between the home and school staff and health and social services, so that everybody's on the same page, that everybody understands the needs of that child, and everybody understands what the challenges associated with FASD if the child is at risk of that. Responsiveness to the individual and their family, and proactivity, so planning ahead for supports or difficult times and being able to anticipate those needs. And I'm sure that you all, that you are all doing this, all the time for all children, but obviously for individuals with FASD, it requires some accommodations. So again, CAN-FASD recognized there was a big gap, that there a gap in knowledge, a gap in training, and education for children's program workers. So we proposed to the Public Health Agency of Canada that we develop and pilot a FASD online training program. They provided funding for us. So the pilot project is targeted at CPNP, Canadian Prenatal Nutrition Program project, and the CAPC project or programs. So there are 236 CPNP projects that serve 45,000 pregnant people, parents, and caregivers across Canada annually. And there are 410 CAPC projects that serve over 225,000 vulnerable children and parents across Canada each year. So we're for now, the pilot program that we've just launched is targeting these programs. So we have the potential in this, in this first phase to reach at least 270,000 people per year. So that, will make a big difference. So basically the project, we did an environmental scan. What we wanted to know, what is there training out there that already exists? Obviously, we don't want to reinvent the wheel. And if, what's out there, what training are our early childhood educators accessing and using. We did a needs assessment, so we did a survey to the CAPSD and CPMP programs, saying, what do you know about FASD? What do you want to know about FASD? How do you like to learn? What's the ideal length of an online training program? We got a lot of information in the survey. So then we put together an advisory committee and started putting together sort of a framework for developing the training materials. And the advisory committee included representatives from CAPC and CPMP programs, individuals with living experience, researchers, clinicians, and FASD, obviously. So we just launched the training on FASD Awareness Day last week on September 9th. And the pilot will go for a year. So the first phase of this project is for CAPC and CPMP programs to do the online training and provide us with feedback. So there's a very robust evaluation that's embedded in the training program. So we will collect all that information, and then we will sort of do an overhaul of the program based on what the feedback we get, and then we will officially launch the program, and it will be available to everybody. So if you are, if you work for a CPMP or CAPC program and you haven't heard about the training, ask your program lead about it. They should have gotten an email from the Public Health Agency with a link. So it's free. Again, we want as much feedback as possible. So we want as many people as possible to take it. But unfortunately, we have no control because the Public Health Agency wasn't able to give us their list of, so that we could send it out or communicate with the programs ourselves. So, and we will obviously give a report to Public Health Agency, and then we'll launch it. So in terms of the survey, like I said, we asked what their preferred training topics were, what kinds of features they liked in an online training program, what their ideal length would be, cost, it's going to be free, what their level of FASD knowledge was. And we had 282 surveys that were completed. So a pretty decent amount, and the answers were very consistent. So, obviously we could have had more surveys completed, but the answers were consistent. So we felt good that we were, that it was pretty representative of our target audience. So the ideal training topics that were identified were assessment diagnostic process for FASD, early intervention strategies, supports for families and caregivers, behavioral challenges, being able to recognize them, and strategies to address them, and then socio-legal aspects of FASD. With the goal of this training and all the training on the CanFASD website is to create an FASD informed workforce. The ideal training length most people said 3 to 4 hours. Some about just a little less than said 5 to 6 hours would be okay. So I think we landed about 4 or 5 hours. It should take about 4 or 5 hours to complete the program. It is free for the pilot, and then once we launch it officially for everybody to access, it'll be very inexpensive. There will be a cost just because it costs us money to host it on our website and to make sure that the evidence is up to date, and just to keep it up to date. So and the same with all of our other online training. So the big features are that it's self-paced, so you can go in and out as as your time permits. There's knowledge checks and quizzes, so we really want to make sure that you're understanding the information, and that you are, retaining the information, and that you're able to apply, what you've learned. And so the application is for, we developed some case scenarios. So that was one of the big things that the advisory committee worked on, was developing those case scenarios. So we wanted them to, not to make sense and to be meaningful, to be able to be used in sort of a team environment where you could, all work on the case together and have a discussion about it and create strategies and stuff. And then, it has videos, and so it's very interactive to keep the learner's interest. I'm not going to go through all this, but we did, like I said, we did spend a lot of time, and we were very, we spent a lot of conscientious about the case scenario, developing it. So that's the landing page. That's what it looks like. We had an amazing web developer that helped us. So it looks a bit different than some of our other courses, but we love it. So we'll be very interested to get the feedback from folks, and maybe we'll, if the feedback's really positive, we'll adapt or update some of our other courses to look similar. So this, there's 45 assessments at the end of each module, and there's 49 lessons. So within those 5 modules, there are lessons within them. So this just gives you a sense of what the platform looks like. So one of the goals for CAN-FASD in terms of policy implications is to expand the training to all early childhood educators, and make the training mandatory. So advocate for more diagnostic services, and ideally build FASD training into college curriculum for these early childhood education programs. So that's it from me. I'm happy to answer any questions. This is sort of where you can find us. And there's all kinds of information on our website. We have a whole e-learning platform with online training for social workers, online training, foundations in FASD, which is really information that everybody should know about FASD. You can email me. It's my name, kathy.unsworth@canfasd.ca. It was on the first slide. Let me see if I can. There we go. Oh, that's still my old title. But same email. You can feel free to call me, email me, and that's it.
Well, thanks so much, Kathy. That was a lot of information, and certainly a lot of great information. And unfortunately, I know some people are having some audio issues, and I'm not sure why. Here, I'll turn my camera on. What was going on there? But I want to reassure you that the whole webinar will be posted to our YouTube channel, so people will be able to watch that in case there's parts of it that was patchy and you missed out. We did put some instructions in there, so people were able to get back on. I did have a question I could throw over to you though. So Elizabeth is asking, in terms of getting an FASD diagnosis, because there is such a range of affects of FASD, how is it diagnosed? And does a parent need to say that they have consumed alcohol during pregnancy?
So yes, most clinics will, because of limited diagnostic capacity, just because there's long waiting lists, you do need confirmation of alcohol exposure. So, but that is generally the responsibility of the clinic coordinator, and they will do lots of sleuthing, and often it is an issue for parents, because it's so highly stigmatized. They don't necessarily feel comfortable saying that they drank during pregnancy, but somebody. So the clinic coordinator might ask some other family members. There are other ways to get that information. The only time we don't need confirmation of alcohol exposure is if the individual, the child, has the 3 sentinel facial features. So we know scientifically that if the individual has the 3 facial features, so the wide they have a flat philtrum, which is the space between your lip and your nose, and they have a thin upper lip, and they have a wider space between their eyes. So those are three very distinct facial features that are associated with alcohol exposure. And so if those three facial features exist, you do not need confirmation of alcohol exposure.
Okay, here's another question. As there are so few diagnostic clinics across the country, are there any funds being used for preventative education? Example, don't drink during pregnancy.
Good question. I mean, the Public Health Agency of Canada has done some prevention education. It's limited. The Public Health Agency does not get a lot of money specifically for FASD, unlike other neurodevelopmental disabilities like autism. That the budget for autism is much higher. It's you know, sort of one of my thorns in my side. Not that I begrudge them the funding, but the prevalence of FASD is so much higher. And at a community level, a lot of communities do really, really great work on prevention to raise awareness about FASD, raise awareness about drinking during pregnancy, you know, to support women who are drinking to drink less. And yeah, I mean, you know, there are 4 levels of prevention, and so that sort of we call it posters and coasters, you know, which is sort of level 1, and then, but it at all levels, like, you know, community, at you know, the public health agencies in the regions, you have their own public awareness campaigns that they do. Labeling in some provinces and territories on alcohol includes warnings about drinking during pregnancy, but lots of work to do in that area.
Yeah, always lots of work to do for that, for sure. Someone else is asking, Irene is asking, why do we have to wait for the child to reach the age of 6 before we can have a diagnosis?
It's not that we have to wait. There are a lot of clinics, some clinics don't have the expertise, so that developmental pediatrician that is comfortable doing a diagnosis for a child that's younger than 6. And often, just as it happens, often it's at that school age where it all really starts to sort of bubble over, you know, where it becomes really obvious that the child is struggling, that, you know, they can't conform to sort of the classroom environment, that they're not keeping up with, you know, they're not at the same level as the other kids in their class. So it's a bit of a combination. It's, you know, often it's just, that's when those kids get noticed or identified, because, you know, you're comparing them to the 30 other kids in the class and thinking, you know, that the teachers may be noticing some of the challenges they're experiencing. And then, yeah, depending on where the child lives, the diagnostic clinic, you know, just may not have the diagnostician that is comfortable or to give a diagnosis for a child that's younger.
Yeah, and I think I'm sure a lot of you have had this experience too when you're working in frontline childcare, but it is a similar sort of experience for speech and language disorders as well. You'll often find that people will there is hesitation for the real diagnosis, so to speak, but it's because oftentimes it could be a myriad of other things going on too. So it takes time, and as the child matures, you get to see clearer kind of what path they're on. And I think as well, I mean, this just reminds me of what I think is really important as a frontline practitioner, is that we need to empower ourselves with this knowledge and find out more about these things. So then what we can do is certainly not diagnose, because that's not our role, but we can set up some red flags and suggest that people go and seek some help and point them in the right direction where they can get some definitive answers. Because while we may not be able to diagnose, certainly that's not our role, but while some children may not be able to be diagnosed, certainly some of them could get some help in the early years if it's looking like it's leading toward that kind of diagnosis is made by a professional. So our role as that frontline early childhood educator and the person who often has a really great relationship with parents is to be that first place to say, yeah, you know, I agree, maybe there's something worth looking into there. And again, not telling them what you think it is, because that's not our role, but certainly pointing them to some places they could go to get information, to get some further advice, or to seek out some more help, because that's certainly something that parents do look to early childhood educators for. And this course that you're going to be having will be amazing for that. I think that will be a wonderful opportunity for us to feel a lot more empowered and knowledgeable about this topic, which is so important. I've had a couple of people who have asked about registration. Where do I sign up? Where do I sign up? All that kind of thing. So certainly, just so you know, we'll be working closely with Kathy and we'll find out all the details about that. And
Absolutely.
sure, we'll send that all through our networks and our channels to make sure that you don't lose the opportunity to find out what's going on with the course and when you can get involved and when you can take it and all those details, because I know we have a lot of people that are certainly very interested in it. There's been a couple of other questions about, yes, okay, so about the certificates, I've answered a few times, but just in case people are unaware, the certificates are auto-generated and they are for the people who individually registered for the webinar, and we can tell on the attendance if you attended for the entire webinar. So because you've attended for the whole live webinar event, you will receive an auto-generated certificate for 1 hour of professional development. And I know sometimes I get emails saying, oh, well, there's 4 of us at the computer. Really best, you know, to be registering as individuals for that, because that's the way we can see it. The other thing, oh, they're asking about slides. So what I did tell people is that we will be posting the replay view of the webinar on our YouTube channel, on the CCCF YouTube channel, and we'll send a link for that in the follow-up email as well, which you'll receive by Friday, by the end of this week, so usually within 2 days of the webinar. And I'm just trying to see if there's any other questions that I could throw over to you, if that's okay. So here's, maybe this will be our final question, because this is a bit of a, it could be a big one. Are there things that ECs can do as early intervention strategies to support young children pre-age 6?
There are, and one of the things that we often say is, you know, that there are like sort of simple accommodations that can be made that are just kind of good for everybody. You know, like, you know, classroom accommodations, like making a little quiet space in where, you know, like a child or children can remove themselves, and because maybe there's too much stimulation, and go and just have some quiet time. You know, turning bright lights off, checking in, making sure that kids understand what is going on, what's being asked of them, asking, you know, kids to repeat it back to you, especially the kids that, you know, are sort of showing maybe that they got distracted or they're looking puzzled, and checking in, you know, with family to see if what you're experiencing in, you know, in the you know, ECE environment is similar to what is happening at home, and maybe asking the families and the parents what strategies they're using that are, you know, are working and or maybe not working, or if you've had success sharing that with the families, so that the child has that, you know, is experiencing that consistency.
Yeah, those are some great ideas. Okay, so I think that is it for the questions. And again, I apologize for those of you who had some audio issues. We did, Suzanne was ever so helpful, and she found some advice for that, and I did put it into the questions. But just so you know, when I look at the attendance for this, I will see that you attended, and you'll be receiving your certificate. And unfortunately, if some parts were patchy and you didn't hear it all, please, I suggest and hope you go to the YouTube channel to be able to review the parts that maybe were a bit patchy for you that you missed. And I think that's about it. So is there anything you'd like to say in closing, Kathy?
In closing, I recognizing that the training will not be immediately available to everybody. So what I will commit to all of you is that I will put together sort of like a handout kind of thing. Like, I know that we have strategies and you know, ideas and things that that you can do to support kids that you know, you think may be at risk of having FASD. So I will pull some of that from the training and put it together in sort of a resource handout and send it to Robin, and she will, you know, she'll send it out. So I'm happy to do that.
Oh, that'd be amazing.
And yeah, and it'll have my information on it as well. So if you want to get in touch with me, you can.
Oh, that'll be wonderful. And then, as I said before, certainly when the course is available and ready to be taken, we'll be giving you all that information as well. So we'll be giving you all that, all the ideas of where you need to access that. So thank you everyone for joining us. And again, apologies for any kind of snafus you might have had with the audio, but I think they got somewhat resolved during the event. And sorry for that, Kathy. I don't know what went on there. We had some gremlins in the machine, I guess. But thank you for your patience, and thank you everybody. And thank you to Suzanne as well. Although we don't see her happy face, I know she's there because she's been scurrying around behind doing messages for everyone. And we look forward to seeing you next time for our next webinar. And we know we usually send out e-blasts about that. We've had some e-blasts out about our next following emails, and certainly our next webinars rather, and opportunities to register. So we look forward to seeing you again. And thanks again for joining us. Thank you, Kathy, for the great information.
Thank you. Have a nice evening, everybody.
Thank you,
Bye-bye.
Kathy, and thank you, Robin. I'm here. I'm just invisible at the moment.
I knew you were there. I could feel your presence. Thanks so much, everyone.
Thank you. Take care.